Hello, everyone. Thank you for joining this afternoon or evening, depending on where you're logging on from in the country. I'm really excited to be with you this evening to discuss fluoride varnish choices. So over the next 40 minutes or so, we'll talk a little bit about decay in general, some of its impact on our country. Then we'll discuss one of our best preventive agents we use in the dental office, fluoride varnish, and some considerations for choosing a varnish product to utilize in your practice. We'll have a little fun with it as I've tried to make the presentation as entertaining as one can make fluoride varnish information, and then make it evidence-based as well. This is my disclosure statement. I am an independent speaker and consultant. I don't work for any particular company. I do, however, have relationships with several corporate entities for the events that I participate in. Thank you to Pulp Dent for providing the webinar this evening. I'm Sherry Lukes. I've been a hygienist for 38 years. Oh, wow. That's really a long time when you say it out loud, isn't it? I look much different now than that, but I spent most of my career teaching and conducting research in the dental hygiene program at Southern Illinois University. Go Salukis! I think there may very well be some Salukis logged on tonight. I hope so anyway. But while at the university, I taught oral pathology, public health, multicultural dental hygiene. I also taught in the advanced periodontics clinic. Since we were a baccalaureate dental hygiene program, we had an advanced perio course, and I taught in that clinic. It was a great job. I loved working with students and doing research and presenting my research. But 5 years ago, I was able to retire. Well, from academia anyway. My daughter keeps saying, "I thought you retired, Mom." But I launched a new career, speaking and consulting. So now I do CE courses all over the country, webinars. I do some writing for several publications, online entities, and journals. My other passion is mission work, which goes right along with my public health background. We do 2 trips per year, one to central Mexico in a remote area in the desert where I still take SIU students with me. And then we do one in the fall to an orphanage that's in Puebla, Mexico. You can see my buddy there. They're so fun. He was actually giving me a pretty hard time that day. But on both trips, we provide debridements, of course, on both the children and the adults. And you know, it can be pretty challenging. We do a lot of sealants, fluoride varnish. I kind of like the duct tape. How do you like the duct tape on the sealant like there? Oh yeah. But you know, the things you do in the field. And so I've used a lot of different products. I like using sealant material that's hydrophilic, meaning it likes a little moisture, because as you can see, it can be difficult to keep the area dry in those not so ideal conditions. As you can see in the slide, I've used a lot of fluoride varnish products as well. We see a lot of patients in the villages and the orphanage. We work with the dentist in both places. You can see him in the background there trying to figure out why his equipment isn't working. So yes, things can be very challenging on the mission field. So that's just a little about me and some of my work, which gives you some insight and applies so well to the topic this evening. But I am a hygienist, and I know we probably have a lot of hygienists on the webinar today. So I am one of you. And as hygienists, we are prevention specialists, aren't we? Typically, we're all about gums or gingiva, preventing gingivitis, periodontal disease. But, you know, we are decay prevention specialists as well. And, you know, we need to be as knowledgeable about that aspect as we are about those gums and gingiva. So whether you're a hygienist or other member of the dental team, it behooves all of us to be as knowledgeable about decay and the different products we use to prevent it in the office, because we're still seeing far too much decay in this country, particularly in children. And, you know, we all know this about decay, or the chain of decay, as we always refer to it with the students. Although we know dental decay is multifactorial, right, with many factors playing a specific role, it's not just about sugar or just about oral hygiene or just about fluoride or lack thereof. It is multifactorial. But at the very basic level, the foods we eat, and particularly sugars and starches, are consumed by the bacteria in dental plaque that forms on everyone's teeth every day, some more than others. And these bacteria, primarily Streptococcus mutans, ultimately produce an acid. And this acid, in contact with a susceptible tooth surface, causes demineralization of the tooth structure, enamel, dentin, producing a carious lesion. And the larger the lesion, the more symptomatic it is. And symptomatic dental caries affects children, and all of us actually, in a variety of ways. Surgeon General David Satcher, in his monumental oral health report of 2000, I actually ran him down at a meeting one time to get my picture with him. But anyway, and you know, I can't believe it's been 20 years since he came out with the oral health report of 2000. But he discussed this silent epidemic of oral disease and how it affects us. You know, it's difficult to concentrate when we have a headache, right? Well, imagine trying to concentrate at school with a toothache. So it definitely affects children's ability to learn. And much school time is lost due to dental disease. You can see some of the statistics in the slide. Give you a minute to look at those. It's quite striking, actually. And then we also know that children and adults, as far as that goes, from low-income families are disproportionately affected by dental caries and actually by all dental disease. In my public health courses, we spent a lot of time discussing the disproportional rates of dental disease among the low SES population as well as other population groups. 75% to 80% of dental decay is found in approximately 75% of the population. I got a little ahead of myself with advancing that slide. So, I used to tell the students, when they ask on the board what's the greatest predictor of dental disease overall, it's socioeconomic status. Now, there's a lot happening in caries research, and this is a great article. I would encourage you to read it if you have an interest in caries research. Lots of research on remineralizing mechanisms and products, from biomimetics to electrically accelerated and enhanced remineralization. Lots of stuff going on in research, but fluoride remains the gold standard. It's the gold standard for arresting caries lesions. Multiple systematic reviews confirming the role of fluoride products in preventing dental caries. It's been around for as long as most of us can remember, and has made a big difference in decay prevalence. And so, just like the chain of decay at the most basic level, fluoride inhibits demineralization, it enhances remineralization, and it inhibits plaque bacteria. We're going to look at that demineralization, remineralization process in just a minute. But we have multiple sources of fluoride now. It's in many foods. We've placed it in our home care products, and it is found in many of our water systems. The CDC lists community water fluoridation as one of the top 10 public health achievements of the 20th century. Adding fluoride to our public water supplies is right up there with immunizations, tobacco use reduction, and some of the other great public health achievements. And even in non-fluoridated areas of the country, people who live there still benefit from products made and packaged in areas that are fluoridated, which is called the halo effect. Because only about 65% of the nation's community water supplies have fluoride added to them. So, but even in areas without added fluoride in the public water supply, there are benefits to those who live in those non-fluoridated areas due to the use of products from areas that are fluoridated. So that's called the halo effect. But those fluoride sources don't do it all, do they? In the dental office, we have several tools in our toolbox to help our patients prevent decay during their preventive care visits. We teach them good oral hygiene measures to use at home and stressing their dental professional on a regular basis. We place dental sealants, which is another great preventive measure. And then, of course, we utilize the tried and true method of topical fluoride application, a concentrated dose of fluoride applied according to caries risk, right? We do a caries risk assessment now to determine if and how often a person needs a professional fluoride application. We still fluoridate most children a couple of times a year. Hopefully, we're not allowing dental insurance to dictate our fluoride services, but providing fluoride in the office based on the carrier's risk. It certainly isn't going to hurt them, but we do use carrier's risk assessment now in our delivery of topical fluoride. And fortunately, we've come a long way in our in-office methods of topical fluoride delivery, haven't we? We've gotten away from those awful gels and rinses. I had so many children when I was in practice who were fine with the entire procedure until it came to treatment. They hated those darn trays, gagging, carrying on. Oh gosh, I think I hated it as much as they did. And so finally, we've started using fluoride varnish. By the end of the 1960s, 5% sodium fluoride varnish was researched and said to be the new application method with a special, long-lasting, intensive fluoridating effect, more so than rinses and gels. It's taken the US a lot longer to get on board with using varnish instead of gels and rinses. We know change can be difficult. I know the preventive dentistry course instructor and myself as a public health instructor, we had a bit of a difficult time when we recommended going from gels to varnishes in our clinic at the university. Fluoride varnish has been used in other countries for caries prevention for years. It's still only approved in the US as a desensitizing agent and cavity liner, and is actually off-label use for caries prevention. But we know that we use a lot of products off-label, don't we? And we know the fluoride is more effective. Fluoride varnish, most of them are composed of a natural resin carrier containing fluoride ions and organophosphoric acid adhesion promoting agents, may include some solvents. And so studies have shown varnish remains on the tooth surface longer than rinses and gels, making it a superior mode of application. It sets as it comes in contact with saliva. And studies have shown that children actually ingest more fluoride with potential to make them, sick or nauseous or cause fluorosis from gels, rinses, and foams than with varnish. There are many on the market, as you can see in the slide, and much more even than in this slide. Durafat there on the bottom was the first one out in this country, and many have been introduced since with a great deal of variation among them. And it's so easy to apply. I used to tell the students, you can teach a monkey to put on fluoride varnish. There's nothing to it. Just dry the teeth a bit, slap it on. Well, no, I do follow a systematic procedure. I do teach them this, or I taught them rather, to start in one area and proceed through. But the point is, it's easy to apply, much easier than those awful trays. But are they all the same? And what do we look for when choosing a fluoride varnish for our patients? Because there are lots of things to consider when choosing a fluoride varnish. So take a look at some of these characteristics. Give you a minute to peruse that list. Do we think about any or all of these characteristics, particularly the first two when we're choosing a varnish? Or are we just focused on taste or flavor. Now, I get it. We all want a pleasant experience for our patients. We want the patient happy, right? Yeah, I get it. But, there's just much more to it than that. Now, manufacturers are trying to make varnishes taste good for better patient acceptance. And yes, we want our patients to be okay with the flavor. So instead of focusing on some of the aforementioned attributes, we tend to choose, oftentimes, based on taste. And we try to make fluoride varnish taste like all kinds of things, or the manufacturers have. From some of our comments, they've tried to make it taste like various fruits, two types of mints, candy, bubble gum. But there's just so much more to consider. There are more important aspects of fluoride varnish than flavor. Are we just concerned about flavor? Or do we know the differences in varnishes and what characteristics can make for a superior varnish product? Not all varnishes have the same composition, nor do they react with the tooth structure in the same manner. It's not just about fluoride. It's not just about the amount of fluoride or the percent of release in varnish products. Since minimal intervention dentistry is the order of the day, and contemporary future dentistry revolves around preservation and regeneration of the dental tissues. We're trying to get away from so much drilling and filling. There are now multiple agents in our in-office topically applied fluorides with various roles in remineralization and other clinical implications. So let's take a look at this whole process, the decay process. The teeth are in a constant cycle of demineralization and remineralization. So dental caries involves demineralization that occurs in response to the diffusion into the enamel or dentin of acids, barrier acids, produced by the karyogenic bacteria that occurs as these bacteria metabolize the fermentable carbohydrates. Calcium and phosphate are the primary minerals that leak out from hydroxyapatite crystals during demineralization. Now, when further evaluating the dental caries process, the acid produced by the breakdown of sugars by the bacteria makes the mouth more acidic, or it lowers the pH. And we understand that the tooth loses calcium and phosphate when the oral pH is low. When the rate of demineralization exceeds that of remineralization with a sustained drop in pH below 5.5, enamel dissolution occurs, and thus the caries process begins. And then you can see in the slide that when the pH of the mouth becomes more basic, the teeth are able to gain minerals once again. So the acids of the plaque and saliva attack the tooth. Calcium and phosphate dissolve from the enamel during demineralization. And saliva and fluoride are two key players in remineralization. It's been said that nothing happens on the tooth until it happens in the saliva. So true. So when the pH level rises, the minerals, calcium, phosphate, and fluoride ions, in the form of fluorapatite, gets deposited back into the tooth structure. Fluoride shifts the oral cavity from a state of demineralization to a state of remineralization. When applied to tooth structure as a topical varnish, the fluoride is dissolved in an organic solvent that evaporates in a moist environment. And then through a remineralization reaction, calcium fluoride deposited on the tooth's porous surface is converted to fluorapatite, making a more caries-resistant surface. So at neutral pH, there is an insoluble reservoir of fluoride from our fluoride sources on the tooth surface, providing substantivity and potentiating those anti-caries effects. The rate of dissolution of the fluoride reservoir increases with a cariogenic challenge and that corresponding drop in pH. So the solubility constants of calcium and phosphate ions are lowered, resulting in fluoride release. And plaque calcium and phosphate ion concentrations are also increased. That's why, you don't have to have the teeth plaque free to apply fluoride. So this mechanism prevents calcium and phosphate dissolution from tooth mineral and or increases the remineralization rate or precipitation of lost minerals. So the past 3 slides and this one are a brief down and dirty, if you will, of the caries process and fluoride's interaction. Now, how fluoride is released from the varnish is important. It needs to be deposited and released slowly for best results. So I used to hate it when people would read slides in a presentation, but you can see in the abstract, low concentrations of fluoride have a beneficial effect on enamel and dentin and remineralization. And it needs to be deposited and slowly released. Phosphate action, very important in this whole process. Different topical fluoride varnish manufacturers have placed various types of additives with claims of aiding in the remineralization process, primarily calcium and phosphate. And so the formulations and clinical efficacy claims vary, as does the research on each. But some examples are tricalcium phosphate, TCP, is added sometimes as an additive. Amorphous calcium phosphate is one of the additives. Amorphous calcium phosphate casein phosphopeptide, ACP, CPP, also known as recaldent, which is a milk protein derived product that we have in a couple of products on the market, and specifically in a varnish. And then a novel method of delivering calcium and phosphate in combination with xylitol has been developed. The xylitol coating prevents early reaction and produces a sustained release of the remineralizing ions, calcium and phosphate. Saliva exposure dissolves the xylitol, frees the calcium and phosphate ions, and then they are able to react with the fluoride and the varnish to form the protective fluorapatite on the teeth. So it's the relationship of the phosphate to the fluoride that dictates a sustained release. There's an immediate burst of calcium, phosphate, and fluoride, and then the release is sustained for up to 4 hours in this xylitol-coated calcium and phosphate product. So let's talk a little bit more about xylitol. I'm familiar with xylitol. I love xylitol. It's a sweetener that's been shown to not only taste good, but we know it provides other benefits as well, certainly in the oral cavity, other areas. My husband puts it in his neti pot. But as far as oral, remember, nothing happens on the tooth until it happens in the saliva. So most varnishes will contain xylitol, about 2%, which actually isn't therapeutic. It's only really in there to take the edge off of the nasty taste of the fluoride. But adding it as a coating to separate the calcium and phosphorus in the products with calcium and phosphorus, it prevents the calcium and phosphorus pre-reactivity. So there needs to be about 18% xylitol to prevent this pre-reactivity. This highly xylitol-coated varnish offers a pleasing flavor, while also preventing the calcium phosphate salts from reacting until they come in contact with saliva. So the saliva dissolves the xylitol, activates the calcium and phosphate ions, which continue to interact with fluoride ions to form the protective fluorapatite on the teeth. So that's how xylitol works in the products that have calcium and phosphate in them, if they also have xylitol. And these calcium and phosphate additives have been found in some of the research to have an effect on fluoride release, specifically the phosphate action. And so, you know, these fluoride varnish manufacturers have various claims associated with their formulations and their superior clinic efficacies. But the presence of additional extrinsic sources of stabilized calcium and phosphate ions could augment the natural remineralization potential of saliva by increasing diffusion gradients, favoring faster and deeper subsurface remineralization. So especially in those high risk patients where we need to get as much fluoride release for a reasonably sustained period as possible, because we know that there will be multiple challenges to keeping the fluoride on the teeth and its uptake. Acid challenges from food, salivary flow and content, oral hygiene practices, and all of the factors that increase carries risk. So the two products in this slide from a dental advisor research report that have significantly better fluoride release both contain calcium and phosphate. The more fluoride we can get released up front, the better. So certainly in some public health settings with high caries rate patients, Very, very important. So we've talked about incorporating these additives. That's something to look for in selection as far as function to aid in the demineralization and remineralization process. Well, let's look at just a couple other things. What about application? What about issues with application? We know that most varnishes have to be mixed or stirred because the components separate. They separate in the tube or the individual dispensing unit, requiring that extra step of mixing before applications. Now, most professionals will mix with the bristles, but actually varnish should be mixed with the other end of the brush. Now, the minute you drop the bristles into the liquid on top, because of the separation, it wicks up the solvents and resins. Then you run the risk of not getting enough of the fluoride salts up as you mix it up. So you may or may not be delivering enough fluoride. And for children under 6, this can be a concern for parents. To prevent fluorosis, it's important to be able to control the dosage. Knowing your dosage of fluoride is important, like I said, especially for young children. So regardless if a product comes in a tube or a single dose, check for separation. And I'd like to encourage you to mix the ingredients with the back of the brush, not the bristles, for best results and to prevent this wicking of the solvents and resins on top. There are a few fluoride varnishes on the market that do not have to be manipulated to account for separation. So that's something else to ask when you're choosing a varnish. There are a couple on the market that in the manufacturing process, more time is spent in the mixing process, so the end product is more homogeneous and therefore don't need additional manipulation to account for separation. In my experience, Embrace is the only varnish that claims no separation. Another consideration is the consistency or the viscosity of the varnish. Does it flow like a rushing river or more like lava over a landscape? Varnishes can certainly be too thin or too thick for good application. We were using one when I was at the university that was just too thin. It needed a higher viscosity. And then, I've had the opposite experience as well. The varnish was too thick to get a good, even application. So looking at that, at viscosity. Then also, do they leave gritty surfaces on the teeth? Some are smoother than others, and whether they're gritty can affect patient acceptance. So that's another consideration. And what about color? Some of the varnishes are still that ugly yellow color. And, you know, an adolescent, for example, is not going to want yellow teeth for the rest of the day. Just saying. Or, you know, what about a business person who is high caries risk? So they need fluoride varnish at their preventive care appointment. So they go for their visit in the middle of the day. They're not going to want to go back to the office with yellow teeth, right? So, you know, color and, you know, grittiness and viscosity, they don't, you know, have anything to do necessarily with function, but they are some other considerations to think about in our varnish choices. So I'd like to, you know, with so many considerations for choosing a varnish product for our patients, I'd like to encourage all of us to concentrate a little less on taste and perhaps more on some of these other characteristics. Does it contain the minerals that are typically lost during demineralization? How is it released? How much is released up front? Does it have to be mixed? How much xylitol is in it? What color is it? So much more to think about than just flavor. When it all comes down to it, you know, it's what varnish has the most benefit for the patient, right? We have to consider what is best for the patient overall. And I know you in dentistry, I know you want what's best for your patients overall. I've never worked with a dental team that doesn't want the best for their patients. And before we wrap up, you know, we talked about dental disease disproportionately affecting certain population groups. And, you know, we see that the older adult population is one of those groups. I studied them when I was at the university as well. And, you know, the pediatric population isn't the only population that benefits greatly from fluoride varnish. We have an increasing older adult population with many, you know, limitations in home care, or some who aren't able to care for their own mouths at all, meaning a greater plaque retention, potential for caries. They may also have a lot of gingival recession with exposed root surfaces, which are high caries risk. So it's very important to provide fluoride varnish applications for these patients. And, you know, those exposed roots, whether in older adults or any patient, as far as that goes, we have a lot of patients with gingival recession, and those roots are oftentimes very sensitive, right? As well as more prone to decay. And we know fluoride varnish is great for that hypersensitivity. That's what it's actually approved for in this country. And so the potential for use among the older adult population and those with root hypersensitivity is very significant as well. So are we simply chasing the fluoride flavor monster, or are we looking at other aspects of varnishes, specifically function? Varnishes containing calcium and phosphate expand the scope of prevention beyond just fluoride concentration. Flavor should never be the primary factor for our reasoning and choice of product. Our job isn't just giving patients something that tastes good Our job, like we discussed, is to solve oral health issues, whether it be decay or hypersensitivity. So what is the best for the patient? You know, it's kind of like having a car that looks great, I feel great in it, I think that car would look good on me, you know, but perhaps it doesn't run very well. It's in the shop all the time, so it's not very functional. And so that rationale can be applied to fluoride varnish choices for our patients as well. So I hope I've given you some pearls to consider in your service to patients today, to perhaps take back to the office. And so I'd like to thank you for attending. This is a list of references I use for the presentation. And if you have any questions that you need to send to me and would like the references, I can certainly send them to you. Here's my contact information. So I hope you have a great rest of the evening, but I think we do have time for a few questions. One of the questions, so I think I can go ahead and ask, answer some of the questions now. One question is, if fluoride is placed at 6 parts per million, should we ask the patient to not brush for the night? I usually do ask the patient to not brush that night to get a better application. What about varnish and peanut allergies? I would have to research that more. Peanut allergies, because perhaps there are nut-based products in the varnish. I would have to research that more. Another, how much fluoride does the patient ingest on average with varnish? I don't recall seeing that in the literature. I think that would be a difficult thing to measure. The research does show that because of how it sets on the teeth when it comes in contact with saliva, the research does say that the ingestion is less than with gels and rinses. With all the products available, which is the best varnish as it pertains to the ingredients in them, I think that is the, I certainly have my opinion, but as far as saying which is the best varnish, you know, the research is mixed on that. I would encourage you to look at the research and what it says about the different varnishes with those additives asked. Youngest age that we can apply fluoride? Certainly varnish can be applied as early as those teeth erupt. There's a question about going along with the peanut allergy. What about a milk allergy? I think perhaps I wouldn't, I would definitely not use the one that has recaldent in it, which because that has that that is a milk-derived protein. So for adults, do you see any big difference between fluoride varnish and foam trays? As far as application, I still would prefer varnish, definitely. And based on Carrie's risk, fluoride varnish is going to have is going to be more effective and remain on the teeth longer. Question: what is the best way to talk to patients about benefits of fluoride, even though they don't want their kids to have it at all? You know, there are a lot of people out there that are still opposed to fluoride. And so I would just stay close to the, the evidence, that the evidence is clear about the benefits of fluoride over the years and the great reduction we've seen in dental decay over the years. And then certainly look at the child's caries risk. And so perhaps, if the caries risk is low and the patient's parent is vehemently opposed to fluoride, maybe we can make a bit of a compromise and not apply it as often. What is your favorite varnish to use? I've used several. I guess I am okay to say that I do really like Embrace varnish. I've used it a lot in my mission work. Thank you to Potent for donating it. But I have been pleased with other varnishes as well. There are several good products on the market, and I am, I do look at the different compositions now as I choose my fluoride varnish products. And I see, when I practice in these mission trips, I do see children that have a lot of decay, so I want a lot of fluoride up front. So so fluoride does penetrate plaque. Yes, it does. Is the patient able to rinse after? Well, certainly with varnish, I think rinsing is okay with water, but certainly we usually recommend that they not brush until the next day. Let's see, where are we on time? There's still a lot, there are a lot of questions. Can varnish be applied to 6 months? Absolutely. We, in our Healthy Smile, Healthy Growth program that we implemented in Illinois, we were advocating fluoride varnish on pediatric patients as soon as the teeth came in. What are your personal post-op instructions with varnish? I typically tell the patient that they can eat afterwards. You don't necessarily have to wait 30 minutes. It's best if they wait a while. However, I do say, perhaps don't eat crunchy foods today because we want the varnish to adhere as well as possible. And then perhaps don't brush until the next morning. Kids like that. See, Mom, I don't have to brush tonight. So, what resources do we point parents to who insist that fluoride is unsafe for their children? I would, there are multiple resources as far as in the research, but I would also, I would send them to the CDC website on fluoride. And there's a lot of good information on there. But if you Google, but now you have to be careful when you Google fluoride, because sometimes you will, the anti-fluoridation websites will come up. And so you have to be careful at what you're reading. Okay, I think that's probably all we can take for this evening. It is what time? I want to look here. So I don't want to keep you any longer. I would welcome emails to my personal email, and I will certainly try to direct you to the appropriate evidence for some of your questions. Again, I thank you so much for joining me this evening, and I hope you have a great rest of the evening.